Good morning, everyone, or good day, good evening. Thanks for joining.
Hey, Max.
Hi. Thank you. So, thanks for coming. We'll start in a minute. Just wanted to thank everybody for joining. This is not the last, but this is kind of like one of the concluding for the time being section on venous things, venous aspects of neurovascular disease. We've, since the beginning of this, we've kind of like wanted to run with the veins because we think they're very important and this and that. But generally, just to highlight, and a lot of this is obviously, as you know, the lectures are available on the YouTube and you can see the recordings of them through the BANANAZ page. You know, we've basically done some work on looking into the various aspects of veins, the conceptual approach to venous anatomy, the ideas behind these like concepts of variation, equilibrium, venous flexibility, like all of these words have meaning. They all have like a substance to them that you can see in the images. And that's reflected and that leads to the pathophysiology of what we do. This anatomy helps us understand like what is the problem with dural fistulas, how they lead to symptoms, and how we can approach them, AVMs, DVAs, so forth. And of course, a lot of this is like highlighted by the maturation of the venous, of transvenous techniques that we've seen over years. More and more stuff is done during, you know, transvenous catheterizations. And a lot of it is safer, a lot of it is more efficacious than going through the arteries for various diseases. So anyway, so basically that's we want to, so we will continue as we kind of move on into July, into like new fellow year. We're going to continue highlighting veins as we move through our program. That's going to be like a little bit more broader arterial wise. But anyway, having said all that, we just want to highlight some of the interesting things in the veins that we probably haven't had a chance to really look at in the past couple of months. So with that in mind, please, if you have any questions or whatever comments, either go to the Zoom chat or speak up. Kitty Pong, we're going to start with, basically we're going to just bounce around, show some things. Kitty Pong, you're on. So Kitty Pong is going to show some of the venous stuff. and we'll open it up to discussion and we'll continue. Kiripong, thank you so much. I'll stop the screen share. You have it.
Okay, I just unmuted myself. Okay, hello everyone again. So we're going to be probably, like Max has said, trying to finish our cycle of this academic year with the venous things. We have done so far only the venous anatomy on this BANANAZ thing. So I've prepared some cases, but I would like to start on this one. It's a lesson we learned. It's going to be a single case presentation, but the case is quite complicated. So I'll start with this slide. You see the slide, okay? Okay, so this is a patient, a 62-year-old male. He started about 12 years ago. He was embolized somewhere else. I don't have his history, what happened to him at that time. But 5 years later, he had this small hemorrhage, and he had a second session of the embo. And you can see, this is a case of dural AV shunt. So you can see the embolization is very strange. Huh? They had the arteries embolized on both sides. Doesn't seem to be near any dural sinuses. Okay, so he was referred to us for his eye symptom like this, like you have it with the cavernous fistula, and also the proptosis. Okay, so I show you the summary of this case at the beginning, just to get you give you the overview of this case before we go into detail. So he came with a shunt like this around the parietal or occipital area of the near the superior sagittal sinus, but the shunt is not at the superior sagittal sinus. It's more on the falx side of the dura. Okay, and the venous congestion was all over the brain, both left and right hemispheres. And we embolized this one quite nicely, but there was some post-procedural venous problem later on. Okay, so this is to summarize the case before we go through in detail. Okay, so this is in 2013. We only have the pictures from 2013 for this patient. The hemorrhage was there like this. This round thing is the venous pouch of this shunt. Okay, so it was a very minor hemorrhage. I don't know what his presentation was at that time. And you can see from the CT, contrast enhanced CT at this time, already he has all this venous, all the collaterals were developing, trying to get to drain the veins out of the brain. And you can see the dilated this superior ophthalmic vein, which led to his symptoms later on. At this time, he didn't have any eye symptom. Okay. You can see there's nothing in the ventricle here, but there's going to be something appearing. So this is probably the first or the second embolization around probably the middle meningeal arteries, which is not very ideal to treat something in this area with this very proximal occlusion of the arteries. Okay, so we go through to get you the whole picture of the shunt and the venous collaterals. So this is in 2018 when he was referred to us. You can see through this contrast enhanced CT for the whole system. I would like you to concentrate on the veins. Okay, maybe I should stop here. You can see the dilated veins in the orbit and probably almost everywhere, but we don't see a lot in posterior fossa, maybe some dilatation. So the veins, somehow they cannot escape too much into the posterior fossa, and part of the, The part of the superior sagittal sinus near the torcula is kind of like thrombosed. I don't know when, so it cannot escape through here. It tries to go through the cavernous sinus, which is not very well developed, or it was occluded. So the major path that it has is to go through this, SOV to get out of the cranial system. Still, the transverse sinuses are still patent. Somehow they try to drain through those sinuses too. But as you can see, also the deep venous system, you can see a venous pouch also over here inside the ventricle itself. So the patient, when he was referred to us, he didn't have any bleedings, but only his eye was like kind of this popping out. So we took him, but a lot of reflux, so we decided to treat him. Okay. So this is the MR on T2. Probably we can see the same thing, exactly the same thing as we've seen on the contrast enhanced CT. Nothing new, but to get to give you the whole picture. You see the dilated veins around here, the peduncular vein, the anterior hemiencephalic vein, and also the ICVs are also dilated almost everywhere. Okay, so angiograms. Okay, okay. To mention again, this man was embolized somewhere else, proximally. So this is the left side injection. We don't see the MMA very well. There's some collaterals that show the distal part of the MMA. Also, the shunt was fed by the arteries of the scalp, like the OA, and also the superficial temporal artery. And the drainage, it's not, you can see it's going everywhere. You can see it probably on the opposite side better, okay? You can see the drainage, it's going backwards up to the superior sagittal sinus. It didn't have any connection to the torcula, so it has to drain like this over the convexity, like this, into trying to escape from the cavernous sinus, but actually it was not working very well out to go out from the cavernous sinus. So it had to go through the orbit, especially in the left SOV. Okay, so this is on the right side. We see a lot more shunt here because the occipital artery is a little bit well developed. You can see the drainage of this shunt is again throughout both left and right hemispheres with final pathway through this superior ophthalmic vein. Okay, so it didn't have any connection here. You see the transverse and the sigmoid, but it was connected not directly. Okay, so there's some like high pressure system there. Some branches from the ICA also. Some tentorial branches from the ICA, and interestingly, as the middle meningeometry was also occluded on this side also, probably this one, this is probably the left side, I'm not really sure. But we can see some collateral, so this is the proximal part of the MMA that was occluded by coils 5 years ago. So we can see the collaterals that it gained from the ophthalmic artery into this MMA system to go all the way to feed the shunt over there because it wasn't occluded at the shunt point. And again, enormous venous congestion. The brain doesn't know where to drain out to. It's very difficult to tell exactly where is the main drainage of the vein of the brain in this kind of situation. It's kind of like it's perfused out everywhere. So this is like a major venous congestion. The same on the left side. The shunt is located, the venous pouch is located on the right side, so it should affect more on the right side, but actually it refluxes through the superior sagittal sinus to go over the convexity to block the venous drainage from the left hemisphere also. So we have, again, quite a remarkable venous congestion on the left side of the brain also. Okay. So So we go on to the left vert, the injected left vert, to see as this patient was embolized like proximally to both external carotid artery system. So maybe this branch was there before, but it was not very evident. But at this time, you can see this dural branch of the PCA was got quite large. And you can see probably the transition between the subpile part and the dural part is probably where it changes the caliber. That's how we believe. So this is the entrance to dura. The rest will be the dural branch here to go into this shunt. Okay. To summarize the shunt point, where is it? I should have made some NPR images, but I put a single picture of a fusion of the injection from the vert, showing the right PCA dural branch into the shunt, and also the left middle meningeal distal branches joining about the same point along the midline. So it's not at the convexity, it's more under the superior sagittal sinus, or otherwise we can say it's on the surface of the fox. Okay, so this is the general anatomy of this shunt. Not a big deal, just to walk you through. So the drainage pattern we have seen, it cannot go through directly to the toricula. So we go on. So the brain, how does the brain drain? It's very important when you look at, you analyze a picture of dural AV shunt. You need to know where the feeders are. You need to know where the shunt is. You need to know where the shunt is draining through. But actually, one of the most important things, and sometimes people overlook that, is how the brain drains. Because without knowing this, you might damage or disturb the brain venous drainage because of your embolization or something. I don't know how this one doesn't work. Okay, anyway, it was so congested. So we tried to get we decided to do a transorbital embolization for this case. Well, the usual axis would be the middle meningeal arteries. We can see the distal part of the middle meningeal artery on the right side. So we tried to go through these coils. Do you think it's possible to go through this? We didn't think so, but it was worth a try because it's less harmful than trying to go directly to the PCA dural branch. We tried it for about 1 hour, different wires, stiffer ones, softer ones, smaller ones, larger ones, but we couldn't get through here. And you can see it's not the real branch of the middle meningeal artery. Actually, this is the probably the proximal part of the original middle meningeal artery, but this is probably the accessory meningeal artery forming a network like at the paracellar area, part of the ALT and so on. So this is probably the part of the recurrent ophthalmic from the ophthalmic artery over here. So there's no direct connection, and we couldn't go through this one either. This one was like a small network, so we couldn't manage to get through that one either. So we switched to go through this PCA dural branch, which was a little bit curvy, but still it was quite straightforward. We went inside. We tried to put some coils actually inside first before we do anything else, but we couldn't enter through this one with those catheters that you can place coils through. So we at the end we just put a magic catheter just to go in there. And when you only have the magic catheter in there, the only thing you can use is only the glue. So the problem of using liquid embolic material in this case, the patient has very, the venous drainage is like converging into the superior ophthalmic vein. Anything that flies into those, the places that the veins converges, it might kill the patient because you might occlude the only exit for the brain. So I was quite. I tried everything else to try to put some coils in the pouch here, just to stop the anything that would fly too far. And we managed to get actually the catheter right. Actually, we could go right into the pouch with the magic catheter. But the only thing we can use is the glue. So this is the injection. This is from the, I think this is in the AP view. I think it was a good injection. We used 60% NBCA. I would like to, it's probably safer to have a more concentrated NBCA. But as you can see, it was quite a high flow. We tried to lower the blood pressure as much as possible, and we got the reflux into another pedicle, arterial pedicle. So this is probably the shunt area, the shunted area. So I think this is good enough. I will go over this again. We would like to see if there was any migration of the glue. Okay, so this will disturb the global venous, drainage of the system, which is already disturbed. So you can see there's a small dot here, not very far away. I think there's another small one here, but you don't see anything that is flying too remote from there. Okay, so on the lateral view, so this is the back. No, this is the back. No, this is the back. Okay, so again, injection looks good. It's like when you do the vein of Galen, but very much slower flow, actually. So we didn't need higher concentration. So this is kind of like a little bit over injected glue, but we don't see anything that flew away that far. Okay, so right after the procedure, so this is the vert. No more shunt here. The feeder stopped here. Same here. Just for the sake of time, go like that. This one actually, I think it is actually draining the brain itself, but you can still see some small residual when you go to the, I think it was the left external carotid injection. This one you don't see a lot, but there's still some very small remnant of the shunt, but we didn't feel that we need to go to get the complete obliteration of the shunt at the time, because we use the NBCAs, and most of the time it will cause further thrombosis, and we can usually expect the shunt to go away. Again, on the right external carotid artery injection, we see a very faint residual of the shunt. And again, I think this in most of the time should be good enough for the shunt to go away later on. So let's look at the normal venous drainage of the brain. The main objective of treating these dural AV shunts is to restore the normal drainage of the brain. So that's what we want to do. It looks nicer because the brain is starting to use the large, the dilated veins over the surface of the brain like this, but you can see some stagnation in the system like this. I don't like to see this at the end of the procedure. Sometimes it means that you reduce the shunt. That's why you see all those stagnations, because you still have the dilated veins. So this on the left side, you can see the veins are flowing, but you can see some stagnation over the surface, lateral surface of the brain, like this. Okay, it doesn't go away because still it doesn't know where to go. We created a new flow pattern. Okay, so this is the DynaCT right after the procedure, just to show you that we didn't have a lot of migrated glue. It was very near to the shunt itself and concentrated inside the shunt pouch. So it was, for us, it was very, we thought we've done a good job. And after this, so this is the MR the following day. So this is the pouch itself. the same thing is appearing on the DWI, but there's no infarct. There's no new changes in the thing, but we can see something over the flare here, a white thing at the left SMCV, so to say, maybe a little bit higher, but it was still filling. This is the contrast enhanced for the next day. We were quite worried about some venous thrombosis that might develop. So we did this contrast enhanced MR, which we usually do not do after embolization of a dural AV shunt. But anyway, the patient was fine. He was heparinized. We heparinized him for 48 hours. Usually we only go 24 hours. For this case, we did 48. And he was discharged. He went back home 5 days later. But after that, 18 days after the embolization, he became aphasic. He was having some kind of a seizure or something. So there was something wrong with his brain. Okay, so we took him back. We didn't take him back. He came back to us, and we did an MR to see that there was something there. And I don't have the contrast enhanced, but anyway, you can see on the T2 on the opposite side, you can see the vein is still flowing there, but on this side, it seems that this vein on the left hemisphere, opposite side of the shunt, the glue must not have been able to flow to fly that far, so it must have been the the change in the venous flow that caused this venous thrombosis and was the cause of his symptom. So we restarted the heparin again, and he was fine, and he was discharged, and well, that was okay for him, but it could have been something more serious. Okay, so we go back to the veins again. So this is the right ICA injection, venous phase, pre-embo. No, this is not the ICA, it's the ECA. Okay, so this is the shunt that was using these veins. Okay, so this is the one that got thrombosed. It was like connection of the vein to the suprasagittal sinus to the probably the SMCV to originally probably draining through the cavernous sinus, but it got thrombosed or something, so it has to go here and crosses to the opposite side to exit through the either this transverse sinus or the superior orbital vein, ophthalmic vein. Okay, so this is after the embo. No, I think I got it wrong. This is before the embo, so we didn't see the brain using. No, this is after the embo. So the after the embo, it has some. It took over this vein a little bit. Okay, but still, it wasn't kind of like using the system freely. This one was probably better. This is ICA, pre-embo. You can see the congestion. The brain wasn't using the system at all. Okay, and post-embo, I think the last one was supposed to be something else. So this is post-embo. You can see the brain is starting to use the system. Okay, it wasn't using it because it was just overtaken by the shunt, but post, the brain took over this vein again. So it was looking good for us. It was like a plus for the brain. So this is again ECA pre-embo, and on the follow-up. So this is what on the follow-up angio. Okay, so we did a follow-up angio after he had his symptoms to see that this vein actually was thrombosed, and well, as we've seen on the MR. Okay, so for this case, I think we did well with the embolization, but for post-operative management, he was probably this patient was supposed to be put on some kind of anticoagulation for a little bit more longer period of time. I don't know how long that is supposed to be. So I just made up this table this morning just to summarize what we usually do for our cases. So this is like our post-embol protocol for the dural AVMs to manage this kind of stagnation in veins. If you have some stagnation in the vein, and also you have some migration of the veins of the glue or embolic material, and we would put some heparin after the procedure. Also stagnation with no venous, like we had for this one, we would put a yes. But for this case, sorry. So if we don't have any stagnations in the vein, usually we don't put any heparin afterwards. But for spinal AVFs, we usually heparinize these patients for like 40 to 48 hours. But for this case, we did 48 hours, but still it wasn't really enough. So every time I ask myself, is it really safe to use heparin after this embolization of dural AVMs? I think it's should be yes for this question, except that those cases with pile supply, because sometimes we see those reports that we have our own case too, that a patient with pile supply, we embolize transvenously, block the vein for dural AV and we still get the bleed like we get in brain AVMs. So these cases, I'm quite scared to use the heparin after the embolization. So another question, I would like to get your opinions too. For how long, if you start the heparin, for how long is the ideal recipe for this post embolization management, and also the dose. For this patient, we used 2 days, but it wasn't enough. Probably he was forming the thing along the way when he went back, or it has already started very early on when he was still hospitalized. I don't know. Maybe we didn't give him enough of the heparin. And okay, so I think we're open for a discussion.
Kitty Pong, that's very nice. Kim Nelson here.
Okay, hi.
Hi. I guess from my perspective, oftentimes over the years, when you have such cerebral venous congestion in a dural fistula, a high flow dural fistula like this, I think it's sometimes useful to kind of have a measure of the EEG going ahead of time and before, because frequently they'll have like aberrant electrical discharge. So we have gotten accustomed to placing these patients on anticonvulsants in the aftermath of their embolization for maybe up to about a month following this kind of embolization. And I think that in your particular case, first of all, there's not extensive venous thrombosis. You have like a small segment of vein that ultimately is thrombosed, and that's not atypical because these veins weren't being used for the brain before the embolization. And so when you cut the shunt flow, they can be recruited and the brain can start draining that way, but it's not necessary. So even if you had surgically taken that vein, the brain already had an alternative way to drain. So I'm not sure that I can link this venous thrombosis with the seizure event. It may be that he was, had already been kendalled, like ahead of time, and just due to the original venous congestion.
But he has have this this shunt for like about 10 years before he came to see us, and I don't recognize any history of having like seizures for this patient. So we just thought that we probably were the cause of the thrombosis and the cause of the seizure.
Yeah, it's possible, but I also have seen seizures in patients like with this kind of extensive venous congestion, especially in elderly patients. When you change the venous drainage pattern abruptly, they can have the evolution of seizures. And going back to more recent cases where we more methodically looked at the EEG, they will have these kind of aberrant discharges, even though they don't have a history of seizures. Some of them will have like staring spells, and if you drill down into their clinical history, you'll see something of that nature that suggests it. But many of them will have aberrant electric EEG activity, even without frank seizures.
Okay, we'll try. I never thought of EEG coming up for this kind of patient. Yeah, that's you can try that. Yeah, thank you.
Yeah. So when you find a patient with this kind of venous congestion, it might be interesting to do like a 24-hour video EEG before you embolize, and then in the immediate aftermath too.
Okay, there's some questions. Okay, any place for direct puncture of the MMA in this case after small craniotomy? I would, we have done more than 10 years ago, direct puncture of the sinus using small craniotomy. But we have been doing great with the new embolic materials. We can go through the branches, the arterial branches, and just inject anything to the shunted sinus. So we haven't done anything in the OR for like hybrid thing. And the puncture of the MMA would be another alternative if we couldn't get into the PCA branch. I don't know, it would be our last choice, maybe last option. I don't know. It depends on if you're comfortable with going into the OR, doing a puncture of that one. Yeah, you can place any catheter inside. Probably it's quite large. And the anticoagulation during the embo, yes, we do. Usually we give heparin during the procedure, but we don't have the optimal dose or how many seconds the ACT should be and everything. Just give some and try to feel comfortable with giving the patient the heparin without any solid evidence or anything.
I might add, Kitty Pong, Kem here again. I
Okay.
think in this question, I thought you were perhaps going to address this. You have two competing things. One is you're giving the heparin to reduce the likelihood of cerebral venous thrombosis, but at the same time, your shunt is not completely closed. And so if you leave someone under prolonged anticoagulation, there is a slight probability that maybe it doesn't advance to full thrombosis.
Yeah.
And you come back with like a little residual shunt at some stage.
Yeah, you're absolutely correct. After seeing a case like this, we tend to give more heparin, but it's very rare to experience this kind of venous thrombosis after embolizing a intracranial dural AV shunt. So yes, we are still reluctant at giving the heparin to this. Yeah.
I just wanted to, it's an awesome case. I just wanted to raise, I'm sure a lot of people in the audience know just some basic things about like the harm of proximal embolizations, right? We don't know where he came from, but those of you that may not have so much experience with shunts, dural fistulas, you see what the attempt that was made to just like proximally coil the middle meningeals converted what probably would have been a relatively simple access to a fistula into something that you had to go through like a PCA branch. And that applies to not just like, this is a very like obvious example of like a very proximal embo, but I think that's what happens much more frequently, probably less obviously, was a closer, but still like a too proximal embolization that leaves the shunt alive. And that's always like the point that we try to stress, that you have to get your embolic material into the vein and understand what a shunt is. The second point is, again, like a general point about how these things evolve. I guess we don't know the evolution, but it's probably, I would assume that at some point the sagittal sinus was open, right? And the drainage was into the sinus. And then slowly with the venopathy or whatever happens, the sinus closes, and that leads to this whole like venous mess that you find with this like whole adaptive drainage. But it's very interesting. Probably at some point, at an earlier point in time, it might have been feasible to reopen the sinus and maybe stent it to give him back his like more normal drainage. At this point, it's probably not going to happen. Any other comments, questions? Anything about, so it's a great, I mean, it's really an awesome case. I noticed, I guess my one question would be, the dose that you mentioned of heparin is like 10,000 over 24 hours, right?
Yeah, that's not a lot of amount.
It's more, yeah, there would be like a kind of a DVT prophylaxis dose. That
yeah.
Continuously, right?
Yeah.
And I don't know, again, it's really hard to know what exactly is the right thing to do. We are probably a little more comfortable with heparin, but there's definitely no standard. So, okay, anything else? All right, keep on, thanks so much. So, okay, we'll go forward. Dan Saline, I think I saw Dan joining earlier. Hey, Dan, dude, thanks so much. Thank you for joining, and thanks for contributing. So we're gonna hear from Dan about a slightly different approach and a different aspect of understanding and appreciating the significance of veins. Thanks, Dan.
Excellent. Thank you. So let's see. How do I?
So,
okay, screen share.
Right. Get that and.
Okay. All right.
Yep, we got it.
Okay. Is this showing you the?
Yeah, that's perfect.
That's perfect. Okay, just the single image, not the presenter view. Okay, great. Well, Max, thanks so much for asking me to present here. This is a little bit different than the general style of BANANAZ thus far. I'm going to be presenting a little bit of my work on brain AVMs, focusing on trying to predict on an individual basis brain AVM hemorrhage. And this is really work that I did at NYU with Kim Nelson and Tibor Besky as well when he was at NYU. I do want to give a quick shout out to my partners. I'm currently at Goodman Campbell Brain and Spine, a very large neuroendovascular practice in Indianapolis, Indiana, that was built by John Scott through his extraordinary technical skill and supported by Andy DiNardo for many years. And most recently, we recruited five-star recruit Krishna Amalaru to join the practice. So thanks so much for having me here. So in studying brain AVMs and trying to look at brain AVM rupture risk on an individual brain AVM basis, I ended up sort of doing a deep dive into epistemology and sort of the theory of science and this sort of thing. So I want to briefly share with you these sorts of things. We'll end up focusing on veins in a way that's a little bit more conventional for BANANAZ, but we have a bit of content to get through, so I'll move fairly quickly here. So my disclosures. So the challenges of studying brain AVMs are obvious. I'll just roll through this quickly. They're tremendously variable. So I asked the question, are any patients truly average? If so, how do we identify those who are average versus those who are not? They're complex. They're sort of difficult to describe. And I think people get hung up, particularly when they first start looking at them, and all the sort of variability and trying to distinguish what is truly nidus from venous outflow and arterial inflow. And they present in young patients, and often the per annum risk is relatively small. So we have to study them over very long periods of time, which is always a major challenge. So in doing so, there are 5 studies that are most cited in the literature if we do a citation analysis in terms of understanding the natural history of brain AVMs. And we'll just shoot through these very quickly just to kind of highlight the variability in brain AVMs and how challenging they are to study. So these are the 5 studies, the Foltz, Crawford, Brown, Ondra, and Mast studies. This is the number of patients that were in each of these trials. The mean follow-up in years, you can see Ondra followed patients for almost 24 years. In general, we take an amalgam of these and we say that there's about a 2 to 4% per annum risk of hemorrhage for brain AVMs. This was supported by the Aruba trial, which showed a little bit greater than 2% per annum risk. But if we look at the variability here in the first year after brain AVM discovery, you can see that we have as little as 0 risk of hemorrhage in the first year in some cohorts versus somewhere between 20 and 30% in others. So massive variability. So are any patients truly average? In terms of annual mortality, we have somewhere between 0% again in some per year versus almost 5% in the Foltz trial for those who presented with hemorrhage. And so tremendous variability, it's kind of challenging to study. So in looking at this variability, we're not the first group to say we want to try to look at brain AVM features to see if any of them are predictive of hemorrhage on an individual brain AVM basis. But in doing so, I think that groups ran into challenges with respect to their approach to this type of science. So if we look at those variables that have been studied and the papers that have shown either an association or a non-association, it looks a little bit like this, where each black circle represents a single paper, which either showed a significant association with hemorrhage or no significant association. And if we look, for example, at brain AVM size, you can see a number of papers have shown us that small size is associated with hemorrhage, but then 2 have shown either no significant or reduced risk. And then others have shown that large size. If we take an even deeper dive into size, oftentimes size is broken down by Spetzler-Martin grade. And so a lot of times these variables are sort of in a database already for another reason. In this case, because they were studied for Spetzler-Martin pre-surgical risk assessment and are sort of thrown into an analysis to see if they might have an association with hemorrhage. But there isn't a real clear hypothesis as to why that might be the case. If we look at venous outflow, I think that this issue becomes a little bit more stark because oftentimes this deep or only deep venous drainage is really looking at the Spetzler-Martin definition of deep. And so we're really looking at brain AVMs that in one capacity or another use the vein of Galen or straight sinus for their venous outflow. But many of these veins, as Max, you have pointed out, and as Kim Nelson has pointed out, are actually superficial veins with respect to the brain. So for example, the basal vein of Rosenthal is a superficial vein with respect to the brain, deep with respect to the surgeon. And so one question is, why are we hypothesizing that a vein that is deep with respect to the surgeon might increase a risk for hemorrhage of a brain AVM? You know, the brain AVM does not know of the challenges that the surgeon faces. Other factors that have been looked at, aneurysms of all different types. People have tried to get some sort of measurement of pressure in arterial feeders and these kinds of things. And we've also looked at some demographics that are not directly tied to angioarchitectural characteristics, such as hypertension or smoking or pregnancy. So I guess we've raised these 2 issues, but I just kind of want to clarify. So I think there's 2 issues related to sort of the epistemology of this field. One question is, I think that we should be asking why, which leads to a more meaningful understanding than the question what. And another way of kind of understanding this is to understand this as phenomenology versus physiology. Phenomenology meaning what we experience sort of in the first person. So like if you're just sort of throwing various variables in and seeing what falls out, that's sort of just kind of what you kind of experience in the first person. But physiology means more like how can we tie our understanding of flow dynamics and things to an understanding of why these angioarchitectural features might predispose one brain AVM to rupture while another does not. And then I think we also have to question the meaning of average. And I think that there is a precedent for this, which I'm just going to get into very, very quickly. But I think it's interesting, and I think it really informs a deeper understanding of this specialty. So this is Adolphe Quetelet. He's a Belgian mathematician and astronomer from the 1830s. And he's the one who really brought the concept of average into biomedical science. Basically, astronomers were using average as a aid for immensely inaccurate measurements they were using with telescopes. They were essentially noticed that if they took 10 measurements and then added those together and divided by the number of trials, they end up with a much more accurate measurement than if they just did a single measurement. And so Quetelet found a database of almost 6,000 chest measurements of Scottish soldiers. And he took the average, which turned out to be 39.75 inches in the 1830s. And what he thought was that this was the true measurement of the male chest. And anything variable from this, he just considered to be error. This was essentially the Platonic ideal of the male chest. So he takes this to all sorts of things. He makes a ratio of height versus weight, which was actually the original BMI. That's actually where BMI comes from, body mass index, that is. And he takes averages of all kinds of other behaviors, some that had never even been thought of, such as the average suicide rate in a population. He was a huge star, and during his time, he was actually as well known as Sir Isaac Newton, which is either heartening or disheartening, depending on your perspective of what happens in science over the ages. So this ends up getting applied to the military by Abraham Lincoln during the Civil War. In fact, he makes uniforms for soldiers that come in small, medium, and large. And this is the first time that small, medium, and large clothing is actually made for the Union soldiers. So just one more slide on this here. So fast forward to the 1940s, the Air Force becomes its own branch of the US military and is increasingly important. And they designed an average cockpit measuring thousands of pilots. They had the best planes, the best trained pilots, and their statistics were terrible. So at Wright Air Force Base in Ohio, a Harvard grad named Gilbert S. Daniels measured 4,000 pilots in 10 dimensions. And he actually found that 0 pilots were average in all 10 dimensions, not even close and found. And so in designing a cockpit for the average pilot, they'd actually designed a cockpit that fit nobody. And so one of the things that I think is sort of applicable here is that in looking at what happens to the average brain AVM, we may actually be looking at an average that applies to actually nobody. And so they made a variable cockpit where you can adjust different components of it, and their statistics actually went through the roof immediately. And so that was the sole issue with the U.S. Air Force. So in trying to understand brain AVMs on an individual basis and trying to sort of think about the physiology, we tried to build a physiologic model of hemorrhage risk using detailed angioarchitectural data and clinical presentation history. We did a retrospective series over 10 years. All the patients were older than 5, and they had to have a brain AVM that presented between 1997 and 2006, and other types of fistulae were removed. Patients with a remote history of treatment were removed. That left us with 121 patients with 122 brain AVMs who qualified for the study. So all charts were reviewed specifically for the study, and all angiographic images were reviewed specifically for the study. And we must have spent hundreds of hours reviewing angiograms for this study specifically. So in our univariate analysis, we essentially found, like others did, that small brain AVM size was associated with hemorrhage, and deep supratentorial location was associated. Other associations included ninal aneurysms and non-peel-to-peel collateral, so non-watershed territory, which others have shown as well. But what interested us more is that there seemed to be a vein dose effect with respect to primary venous outflow and the brain AVM. So if we look at venous number here, 1, 2, or 3 or more, the association with hemorrhage with single venous outflow was 73%, 2 was 46%, and 3 or more was 30%. So it seemed to be almost a vein dose effect. And single draining vein was statistically significantly associated versus multivenous outflow with hemorrhagic presentation on its own with an odds ratio of 4.5. There were others that were statistically significant, including venous outflow stenosis, as well as what we called intrinsic venous collateral potential, which we'll get into in more detail in just a moment. This was actually protective from hemorrhage. That's single draining vein, and you can see once again the odds ratio was 4.5. So increased risk with single venous outflow. So we propose that the association between brain AVMs with single draining vein and hemorrhage seen in our study and elsewhere might be related to outflow impedance. In this hypothesis, brain AVMs with higher numbers of draining nidal veins would be protected from hemorrhage by lower outflow impedance, whereas those with one draining vein would be at risk because of their relatively constrained higher outflow impedance. Variability in the dispositions of venous drainage among the brain AVMs in our cohort provide an opportunity to test this hypothesis, and here is how. So 2 special dispositions of venous drainage were identified, each reflecting different capacitance or impedance conditions. In the first case, we had brain AVMs with multiple draining veins, some of which were constrained by an outflow stenosis, provided a group mimicking single venous drainage physiology. Brain AVMs exhibiting multiple secondary venous outflow pathways, which we called increased venous collateral potential, which I'll define in just a moment, comprised a group angiographically felt to exhibit features of increased brain AVM output capacitance. So what was IVCP, or increased venous collateral potential? These were redundant venous pathways confluent with the principal draining veins outside of the nidus boundary in the composite drainage of the brain AVM. So what does this look like? So here's a 36-year-old with a 3.5 centimeter brain AVM. There are two draining veins from this, primary draining veins from this nidus. But if we look at a slightly later phase here, you can see that there are then multiple veins that come off of those two primary veins to add to the increase to the venous collateral potential. And so two primary veins, and then, I don't know, 4, 5, 6, 7 additional veins that we called increased venous collateral potential. Here's another brain AVM, this one a posterior temporal brain AVM here. You can see that there are 4 draining veins. There's actually a stenosis in one of these, which we identified as around a 70% stenosis by NASCA criteria. And while there are multiple 4 primary draining veins, this one also has increased venous collateral potential. You can see these additional veins that have been recruited from the primary veins outside of the nidus boundary. Okay. Here's a super selective injection showing that this physiologic compartment has 2 draining veins, and further identifying the stenosis from one of them. So when we look at AVMs with 2 or more draining veins, and we look at those with a stenosis, around half of them are presenting with hemorrhage, whereas we look at those without a stenosis, only around a quarter of those were presenting with hemorrhage. And so this was statistically significant. And note that the odds ratio gets very similar to that seen with single draining vein. So we saw this as validating of our hypothesis based on venous outflow impedance. Additionally, if we look at those with multiple draining veins and venous collaterals, you can see that around a third of those are presenting with hemorrhage. If we look at those without venous collaterals, over half of them are presenting with hemorrhage. So the increased venous collateral potential actually was protective, and this was statistically significant as well, with an odds ratio of 2.5. So now if we combine those and we say, well, if you have a stenosis and you have venous collaterals, you can see that around 40% of those are presenting with hemorrhage. But if you have a stenosis without the protective collaterals, 3/4 of those, 75% of those present with hemorrhage. So again, it makes sense with respect to each of these architectural features and their potential physiologic significance. If you look at those without a stenosis, if you have no stenosis and you have venous collaterals, only 3 out of 25 of those patients presented with hemorrhage. So you have both kind of protective mechanisms. If you have no stenosis and you have no venous collaterals, you can see that around almost a little more than a third of those presented with hemorrhage. So when we throw these into a multivariate logistic regression, you can see that all of these are statistically significant, and there's a trend towards significance for presence of nidal aneurysms, a little bit of a different feature without the same sort of physiologic implications. So the next thing we thought was, well, maybe some of those other features that both we and others have shown were statistically significantly associated with hemorrhage, such as small nidal size or deep location, maybe those were just heavily associated with these features that we thought had more of a physiologic significance. And so we did a test for dependence. And if you look at one draining vein, there was an 80% agreement with small AVM size, an 84% agreement with deep venous drainage only, 71% agreement with absence of PL to collaterals or non-watershed territory, and a 75% agreement with deep location. So in all cases, these are heavily associated with the features that we thought had more of a physiologic kind of correlate. If you look at absence of intrinsic venous collateral potential, you had a 70% agreement with absence of PL to collaterals or watershed territory, and a 67% agreement with deep venous drainage only. Again, highly associated with these other variables. And if you look at increased venous collateral potential, you have a 75% agreement with larger size, and large size had an 80% agreement with multiple draining veins as well. So in each case, highly associated. There's one other feature that I want to discuss briefly, which is that this kind of idea of seizure is associated with angioarchitecture. And so in our case, if you have multiple draining veins and you have a stenosis, it looks like venous collateral potential is protective. However, as is often the case in this field, there's no free lunch. So there's long been an association in the literature between presentation of the seizure and decreased risk of hemorrhage or death. And this has never quite been explained. If you look at this study, the Ding study from World Neurosurgery from 2015, the strongest independent predictor of seizure presentation was lack of AVM hemorrhage. So non-hemorrhage heavily associated with seizures. If you look at the Foltz data, seizure patients, you can see, have about an 85% good or fair outcome over the entire length of the study, whereas patients presenting with hemorrhage, only about 35% have a good outcome, so much lower. If we look at the Crawford trial, there's a 42% chance of hemorrhage overall over 20-year follow-up, but only 30% risk for those who present with seizures. If we look at the Liu study from BMC Neurology from 2015, there's a higher risk of seizure occurrence observed in large size and unruptured brain arteriovenous malformations. In other words, unruptured brain AVMs heavily associated with seizures once again. So what do we show? So essentially, if you look at brains with venous outflow stenosis and multiple draining veins, overwhelmingly, these patients actually have seizures. So you can see that with venous collaterals, you can see that you have almost a 40% association with seizures, and without, only 2 of 15 patients present with seizures. And if we look at the logistic regression of IVCP by venous stenosis, you get statistically significant. So while the increased venous collateral potential is protective by lowering the outflow impedance, you're spreading increased venous pressure over a larger cortical territory and is putting you at increased risk for seizures. And something very similar was actually shown in the Shankar study by Dr. Kring's group. They found fistulous components of the nidus, venous outflow stenosis, and the presence of a long peel course of draining vein were identified as the strongest predictors of seizures. So venous outflow stenosis in the same way that we did, and they identified a feature called long peel course, which is sort of similar to what we're saying with IVCP in terms of spreading increased venous pressures over greater cortical territory. So I'll just wrap up here. In conclusion, we were looking at a sort of physiologic validation of the impact of single venous drainage anatomy. Specifically, the hypothetical physiologic implication of single draining vein was explored and validated by examining distinct sets of brain AVM with multivenous drainage characterized by different outflow conditions. Drainage was constrained by stenosis, mimicking the outflow physiology of single venous drainage, and the risk actually became very close to single draining vein physiology. And outflow capacitance was increased by greater intrinsic venous collateral potential, which is extremely protective. And those two factors in combination worked as we might expect. And without a stenosis and with IVCP, very, very few patients presented with hemorrhage. Whereas if you had a stenosis and no IVCP, 3/4 of the patients presented with hemorrhage, even with multivenous drainage. So this paper was published without the IVCP in stroke. We couldn't get reviewers to sort of understand the concept of IVCP in stroke. And so from 2014, if you want to check out the publication. So just like to acknowledge Kim Nelson and additional support from Tibor Besky and Paloma Mora at the time. So thank you very much. Happy to take questions or discuss further.
Dan, thank you so much. Thank you. It was a lot. I think there's going to be a lot of questions. Let's look in the Zoom chat. Ryan just came up, question for all. Can you see then? You see the Zoom chat?
Let's see here. Let me just, okay. Okay, all righty. Question for all. Are we sure we can distinguish stenosis from a cortical vein becoming tentorial before dumping to a larger sinus? Yeah, that's a great question, and I think that there are challenges, especially as the vein reaches the sinus. I think we had super selective catheterization overwhelmingly for these patients, and I think that helped us to sort of clarify because we were able to, even in multivenous outflow, identify veins on a physiologic compartmental basis. And so I think that was extremely helpful. I'll also add the superselective catheterization was also extremely helpful for other angioarchitectural features such as nidal aneurysm. It's interesting, if you look at the literature, those papers that look at superselective catheterization in terms of identifying the incidence or frequency of nidal aneurysm show very high, like greater than 60%. Those that are doing catheterization from the internal carotid artery or vertebral artery more proximally show much lower percentages, 15% or less. So you have massive differences based on whether or not you do super selective catheterization. But we were very careful in addressing that. I think it's a great question, and I think that the very careful super selective catheterization that Kim had been doing for years was very helpful in assisting us.
Okay. Anything else? Kim, I don't know if you're listening, if you have any comments.
Yes, it was fantastic, very quick, but a very nice survey of the whole thing. And I like the philosophical challenges. But you wonder, like if from Kitty Pong's previous, case, that in a dural fistula, even where you have like venous drainage distributed over the cerebral hemisphere, to what degree does that put you at risk of seizures? And so it's just an interesting correlate. And I think at some point we're going to have the venous collateral potential concept published also.
Dan, it's Ethan here. Have you had any case, or have you ever heard of a case in which like palliative treatment was done, like treating the culprit of the hemorrhage, which, yes, it's the AVM, but it can be like the stenosis of the vein. Has there ever been like such a case in which that was a consideration?
Kim, do you want to comment on that? Because in our embolization study, we commented on one of the patients where the goal was more associated with venous outflow than it was a nidal or flow related feature.
I think that that commonly comes up in difficult to treat AVMs where you can't arrive at a definitive treatment, large, complex, high Spencer-Martin grade lesions that get into trouble with either seizures or with hemorrhage. And so we have, on occasion, there have been a few cases over the time where we couldn't arrive at a definitive treatment. This is prior to staged gamma knife. Done targeted embolizations, not targeted toward a specific angioarchitectural weakness, but targeted to reduce the physiologic bulk flow through the AVM. Maybe occasionally to address, say, a venous ectasia that's hemorrhaged or something of this nature, just to reduce the flow through that structure. And so I do think it plays a role in like in targeted embolization to address a physiologic concern in complex AVMs.
And we can maybe follow up and show a case of that we've done recently. But then I guess I had one question about, I guess I was thinking of the analogy with, like, say, aneurysms, right? Like small aneurysms, lots of ruptured small aneurysms versus, you know where I'm going, like most aneurysms that are ruptured are small yet whatever incidental ones. So the question, I guess, is when we come across like the whole spectrum of bleeds that arrive into the ER, right? Oftentimes in the AVM, we can identify some culprit, right? Perinidal interest, some kind of like obvious source of rupture. And our approach to that is generally like knock that down, wait for them to recover, and then do something else later, right? So how does that like play into the model of like, are these, like, I guess the questions would be, are these AVMs, how do they present? Are these hemorrhagic presentations at baseline or not? If they are not, if they are, like, does that model still apply? Or is that a consequence of the venous issues that we've seen?
I'm not sure. So could you say that again in terms of, can you just ask the final sort of question again, Matt?
Yeah, I guess I'm trying to make, so like let's say a ruptured AVM, there's a bleed. Oftentimes, I don't know if you agree, like oftentimes we can find the place where it bled.
Yep.
And that's going to be like something that we can selectively target. How does that relate to your findings? Like, is that something that you think arises because of some venous hypertension?
That's the idea. Yeah, that's the idea. That it's, you know, you have there's this stress on. I mean, these are mostly talking about sort of intranidal hemorrhage, you know, and so you have these sort of three compartments. You have this arterial inflow, and you have this nidal compartment, and then, you know, in our findings, the greatest determinant that we could model that was associated with hemorrhage was venous outflow. And yes, that essentially you have some AVMs that have single draining vein. You have some that have multiple, and then you know, you have these other features that that modify outflow capacitance, and that, you know, if we think of these as sort of developmental, and I know that this is a little controversial, but if we think of these as developmental, so this thing is around for a long time, and it's you know, you're looking at some sort of probability distribution over all that time, and you know, there are things that might be changing as well. So there's stenoses that might be developing in veins, and so if a stenosis develops, you either develop new collaterals outside of that vein, or at that moment, potentially you hemorrhage if you don't have that venous collateral potential from that outflow. And so some of these things might just be like some spontaneous thing that happens at that moment, because with every heartbeat, you have some sort of probability distribution that you're looking at in terms of rupture. And other things, we might be looking at a brain AVM that is changing over time, recruiting you know, veins, or developing stenoses. And that when that happens, you're either looking at a new state that's higher risk because you have higher impedance, or you open up these new collaterals and the impedance is lowered.
Yes, Max, if I might also kind of add, you know, so you have two issues. You have like an anatomic site that a lesion ruptures from, and then you also have the physiology of the global nidus. And so not to dismiss, you know, the role of aneurysms, because, you know, many times the lesion will have ruptured from either a venous side aneurysm or an arterial side perinidal aneurysm. But the effect of the outflow impedance is with respect to the physiology of the AVM nidus. And so that aneurysm, perhaps if it's pre-existing, it's more likely to rupture under certain circumstances, physiologic conditions, or the aneurysm may form de novo as the lesion ruptures. So not to dismiss the angioarchitecture site that we typically target with an embolization in a ruptured AVM, but to sort of express why did that lesion rupture at that moment. And that is more related to the physiology of the nidus that's, you know, many times governed by the outflow impedance.
Thank you. I guess briefly, just one more comment. And I think we again see that playing out like across the spectrum of neurovascular disease. Like, for example, when we think about aneurysms, right? The classifications of aneurysms have often previously, historically, have been based on surgical considerations, right? Like, and I think with AVMs as well, and we all understand that the Spetzler-Martin system is basically like just has to do with estimating what would be the surgical risk of resection. But in some, maybe the psychology of it is that it's driven a lot of the, as Dan, you mentioned, right? It's driven a lot of the research into that, into the kind of like the idea of looking at size and all these deep veins. And I think I just want to highlight that what you show is a different approach. It's an approach that's not, has nothing to do with the surgical considerations, right? It has to do with an entirely different set of parameters. It's about physiology, it's about rupture, and it's a whole different territory. And I think we haven't done as well as you show, we haven't really done as well in exploring that. And probably given like how things are going, that's where the future is looking more into that and understanding more of what you're doing.
Yeah, I think it's a great point. Yeah, and I've, you know, I thought that even though this is a little bit of a departure for this series, I've so thoroughly enjoyed everyone's talks, and I thought that, you know, in this group particularly, people are always doing a deeper dive into physiology and exploration, and so I thought it was kind of consistent with what you guys have been doing. And thank you for having me, and thank you for all the extraordinary talks that people have been giving.
And thank you. Yeah, thank you. Thank you very much.
Thank you.
Okay, if there's no other questions, comments, we'll, when we go on, Eitan, do you have, if you have, we can show a few other things and veins that we haven't touched on.
Yeah, I can show something. Okay. Give me a second here. Okay. So I'll show a case in which some of the anatomical topics that we discussed in the last months come into play. This is again, name is anonymized. This is actually a man in his 40s who presents to our emergency department for progressive swelling in the right eye, redness, and mild headache, not much pain. CT is done, and the CT shows CT of the orbits, confirms that, I mean, we know about the proptosis from the physical exam, but we see that there's really like no retroorbital mass, no intraorbital mass, sorry, but you know, there is the appearance that the right cavernous sinus is enlarged. He has an ophthalmologic consultation, and they identify these corkscrew vessels in the sclera, and the pressure in the right eye is slightly higher, and they certainly like consider carotid cavernous fistula as one of the possibilities. He goes on and undergoes an MRI, and the MRI shows that the superior ophthalmic vein is patent, is not too large. There's certainly like increased flow voids in the region of the right cavernous sinus. And interestingly, this is a sort of a subtle finding on this particular sequence, but you kind of identify here that the veins along the insula and the cortex here, these are slightly enlarged compared to normal. You can compare the right side to the left, and but the sequence that becomes better to identify this is actually like the post-contrast. Let me see if I find it. Yes, the post-contrast sequence is here, and here it becomes very obvious that the veins on the right side are enlarged and congested, and everything though is pointed to this region, the region of the right cavernous sinus. Again, the superior and the inferior ophthalmic vein are not enlarged per se, but certainly like we understand how his presentation is probably related to this lesion. Next is if you want to confirm the presence of a fistula, we think certainly that the MRA is the best sequence, because it will show like arterialized flow-related enhancement or arterialized flow in the region of the right cavernous sinus. And but there's more. There's actually an extra layer of evaluation that you can make on this. For example, like you can recognize here, there is a branch that goes through the jugular foramen. Okay, there's a branch that goes through the hypoglossal canal. The branches actually like converge to form this artery along the clivus here, and we know this is an artery, right? And then, for example, also like we see that there is a branch coming from the left cavernous ICA, which seems like an artery, and it seems like to cross through. And the middle meningeal artery doesn't seem like particularly enlarged compared to the left. And anyhow, what we see here confirms that there is a right carotid cavernous fistula. Looks like an indirect carotid cavernous fistula. And the next step is to do an angiogram. Bring the patient for an angiogram, and we start from the left side, and here from the left becomes very actually like immediately obvious on this like late sort of like early arterial phase, how we see like filling of the right-sided cortical, like deep middle cerebral vein and cortical superficial veins from a fistula that is located in this region. Now, one of the question on this particular image is what are we looking at here? Is this a vein or is this an artery? And this becomes actually an interesting question, because the appearance of this is a little peculiar. If you look at this magnified view, you see how it doesn't seem like one single channel. It's sort of like a plexus of vessels, okay, that is filled by the left meningophyseal trunk. So it has the appearance of what can be called a vein. It's just the whole understanding of the disease and the location of the disease that we will get with the whole angiogram that we will tell us that this is indeed an artery. Going forward, we actually did this 3D from the left side that turned out to be very, very useful, because it shows us selectively the right cavernous sinus. Injecting the contralateral ICA, in this case, it gave us the privilege to see the fistula on the right side without seeing the superimposed right-sided vessel that would have obscured the selective view of the right cavernous sinus and its outflow. So this turned out to be a very important sequence to create some reconstruction that I'll show you now, since we're on this image. But these are reconstruction of the right cavernous sinus made with this selective left ICA injection. And you know, we can go a little more deep into this anatomy, but essentially this is like the superior ophthalmic vein. So this is a lateral view of it. This is the superior ophthalmic vein. This is the inferior ophthalmic vein. This is the anterior part of the cavernous sinus.
Eitan, sorry, the image is a little bit off to the left, so it's hard to see. Yeah, can you center it? Yeah.
Yeah. So superior ophthalmic vein, inferior ophthalmic vein, this is the anterior part of the cavernous sinus. And we can see how things are connected, really. Like you see like that, this is the deep middle cerebral vein here. And you see that how the cavernous sinus is really made of compartment. We went through this in the talk about cavernous sinus. And this is really like, it's a concept that is magnified and very well illustrated in such an image. And we know like that in order to close this fistula, we really have to get to the compartment, to the right compartment. If we just, for example, close this particular area, we're not going to cure the fistula. So after the complete understanding of the anatomy of the fistula, like going back to this particular image, we really make it easier to make a plan in order how to cure it. So going forward with the angiogram, certainly like there is also like a little supply from the ascending pharyngeal artery through this clival that again goes to the same channel toward the right. This is a frontal view left external carotid artery injection. And moving to the not much interesting part from the vertebral circulation, but from the right ICA, we see certainly like the supply to the fistula from MHT, ILT. I'll show you better on the magnified views. Here we see the early opacification of the cavernous sinus, enlarged MHT, ILT, and we see from the external like injection, we see like the filling of the same branches, but from the collateral, from the external circulation. So we see very well here. So we have the external carotid artery, superficial temporal artery, internal maxillary artery, and here we recognize this vessel from the distal maxillary artery. It goes back. This is the artery of the foramen rotundum, and here it really meets like the arcade around the carotid artery, where it meets also the ILT. But all the flow tends to go toward the fistula that we see here, partially opacified. Another vessel that we see here, this is the accessory meningeal artery going up, and we know it goes through the foramen ovale, and then again, like reaching this network of the fistula. Now, this is a distal right external carotid artery injection. You see the catheter is almost at the level of the IMAX. So we know that there's one vessel that is missing in this injection that can be very important, which is the ascending pharyngeal artery. And so we have to keep that in mind. We have to do a more proximal injection, and this is it. Now with this more proximal injection, you see how there is this extra vessel that we didn't appreciate on the injection before. So this is a lateral view, and this vessel is along the clivus, and it happens to be that vessel that we saw and we knew of its existence on the MRA. And this vessel is actually, like, we're gonna understand it better with other injection, but it's essentially made of these two branches, one that goes up here, and then two that reaches here. This was the jugular branch that we saw on the MRA very well, and this is through the hypoglossal canal. And both joins together to form this artery that reaches the back of the fistula. So this selective injection really help us to understand where is the fistula, like in terms of like comparison with the cavernous sinus, and the fistula appears to be like posteromedial. I will show you this Dyna CT, which is very beautiful and really like show us very well all the things that we described so far. So so we see that clival branch that goes up, and then here it is joined by that branch from the MHT, that clival branch, and really like it's obvious that this is the location of the fistula. So this pouch, medial posterior pouch of this cavernous sinus is the location of the fistula. So the other branch that we recognize through this view are, for example, like this is that accessory meningeal that goes up through the foramen ovale, and then here we have the middle meningeal through the foramen spinosum, giving a little branch but not too much, and then here we have the artery of the foramen rotundum, beautifully illustrated. We really recognize the foramen rotundum, and the artery goes back, very sort of like a corkscrew vessel, classical appearance joining the other arcade. Through this image also we can understand better the anatomy of the cavernous sinus. So here again, like this is the anterior part of the cavernous sinus where we have the superior ophthalmic vein joining, okay? And here we see like how this is obviously connected with this deep middle cerebral vein, but not directly, okay? And we also can recognize some route to get potentially from there to the posterior medial pouch, which is the site of the fistula. Now, another important note to make, as you see, there is no opacification of the inferior petrosal sinus. If anything here, like we see that there was one in the past filling. We see like the shape around the shape of it and the direction of it, but it's certainly not filling, and we didn't see it on any injection. Again, we can do this Dyna CT image. We can reconstruct them on every single plane and really like to understand this anatomy as in detail as possible. So this is the angiogram, and so now we plan for treatment. So when plan for treatment is done for something like this, like obviously we have to think of like I would say there are three options here. Option number one, try to recanalize the inferior petrosal sinus, something we discussed in the session of cavernous sinus. There are different techniques, and it's something that potentially can be can be safe, meaning that would bring to a transvenous embolization of the fistula, which is probably safer. But the problem is that you're really navigating in the dark because you don't see or pacify the vessel that you're trying to reopen. Other option is transarterial embolization, and we demonstrate quite a few vessels that are supplying this fistula. And so matter of choosing the right one, but that's certainly an option here. The main risk of such a thing are two, like the reflux to like the ICA, which is really like in the area, versus embolization of supply to cranial nerves, causing cranial nerve palsy, which the patient doesn't have at this point. His only problem is really proptosis. And then last consideration is certainly like a direct transorbital embolization or with the direct puncture of the anterior part of the cavernous sinus. So we started the case trying to recanalize the inferior petrosal sinus, and we did like so. So here you see like it was really like not visible, but you know, with a gentle catheterization, we could manage to bring a microcatheter. So this is a lateral view. You see here like the microcatheter tip in the upper aspect of the cavernous sinus, and this is an injection from it. And from this injection, you see that like we are certainly like opacifying some of the veins in the area, the clival plexus, but there's really like no connection with the right cavernous sinus. And we tried, no matter what, we tried to catheterize that. This is a frontal view. Probably this is one of these two is probably like the entry point of the right sixth nerve. And so we try no matter what to like catheterize and find a route from the wire. But really like we tried quite a bit, I would say, for around half an hour or so, but really like with no result. This is just a double mask that shows the relationship between that injection from the inferior petrosal sinus to the ICA. We're very close to the fistula, which we locate around here, but there's really no visible connection. And it's not improbable that, you know, a connection doesn't exist, or, you know, like, or probably like the fact that the inferior petrosal sinus wasn't opacifying tells us that it was a thrombose. So likely there was a connection here, but it becomes like trying to catheterize this wasn't successful. So after this, we moved to explore like the transarterial embolization. And again here, what we see is a lateral view, right ascending pharyngeal injection. You see the catheter is here in the ascending pharyngeal, and we see better like this supply to the fistula from this clival branch, again supplied by the hypoglossal and the jugular division. The jugular division, interestingly, comes directly from the occipital artery. So let me show you that. Okay, yes, this is the occipital artery, and you see the jugular division coming directly from the occipital artery. This is not an extremely rare variant. Okay, in this case, again, the neuromeningeal trunk is essentially split between the ascending pharyngeal itself and the occipital artery. And we thought this would have been like a good route for catheterization. So we explored this, and here we have the catheter wedged around in this location. This again a lateral view. This is the catheter that we left in the inferior petrosal sinus from that catheterization, but our current catheter is around here. From this injection, it seems like we could have had a good opacification, a good filling of the fistula. But at this point is where like it's important to consider your risks. And going back to this image, so one of the things that here it really becomes important is the connection with the collateral connection with the supplier from the ICA. So is it possible that if we inject the glue, like from here, is it possible that we have retrograde filling of the ICA, causing potentially a catastrophic complication in such a patient? So how to explore that? At this point, we now in this particular image is not representative of what would be the flow toward the end of your glue embolization. This is representative of what the dynamic of flow is at the beginning of the glue embolization. But once the glue starts closing some of the pouches here, the hemodynamic change. And at that point, those connections with the ICA can manifest and become problematic. So in order, one way to explore that is to try to inject very hard, try to do a very hard injection. And there we are, like same view, like lateral view. We see very well the filling of the fistula with this deep middle cerebral vein. Now, on this particular image, though, you recognize this particular thing. Okay, so this is a hard injection, very hard, in order to explore these hemodynamic potential collaterals. And what we see here, essentially, this is the ICA. Okay, so there is a little filling of the ICA from the connection between the clival branch of the ascending pharyngeal to, like, with a collateral arterial to arterial connection with the same area that is supplied by the MHT. This is the little MHT that comes from here, from the cavernous segment of the ICA, and gives off this vessel. So if you inject hard enough, you can explore this collateral connection between the two vessels. So, but this tells us that there is a risk. There is a risk of something like a transarterial, like glue, like filling the collateral and then coming back and embolizing to the brain. Now, this doesn't mean that this is not a feasible thing to do, but it's something that becomes a little riskier. One way, there's certainly ways to protect you from this. Like you can inflate a balloon around here. It would be like a long balloon also to protect from the ILT. So that is a consideration. But at this point, we decided to explore the last sort of approach that I mentioned to you, which is the direct approach to the cavernous sinus. So a note on that. So we did a 3D of the bone just to have a good perspective. We can do with the Siemens machine. We can do those kind of needle like guidance views. Essentially, like the area that has to be hit is the inferior right aspect of the orbit, and the best view to get to the posterior cavernous sinus is it has to be an oblique inferior view of the orbit. You see here the orbit, and you have to see in your image. You have to see the. This is not a good. I have the. Too many images here. Yeah. So so this is the view that we need. So this is like a 3D showing the vein in the back, and you want a view such like that. So you want to go along the floor of the orbit, okay, and you want to hit this part. This is the optic foramen, and obviously you have to stay very lateral enough to that. This is the supraorbital fissure here meeting the inferior orbital fissure. And the vein, the anterior cavernous sinus, is really the connection between the two. So this is the point to hit. And the way you want to hit this point is really by going along this lateral aspect of the orbit straight. So this is the needle, and you want a lateral view to make sure how deep you go, and make sure obviously you don't touch the carotid. And this is the progression of the needle, and at a certain point there is blood return, and that is at this point there was blood return. So with the needle in this location there was blood return, and this tells us that we're inside. Just a note: this is just a Seldinger needle. An 18-gauge needle is enough to carry a 21 catheter, and so this is now the navigation. Once there is access, like navigation becomes, in this case, it was not difficult. It's really like it was relatively straightforward to get to the area of the fistula. You want to confirm that you're in the area of the fistula. So what we did here on this lateral view, what you see, we injected first from the vein. Sorry, let me go back to the first images. Okay, so first from the artery, actually, we still have the microcatheter in the ascending pharyngeal artery. So we inject from the artery, okay, and we see that this is the initial pouch. And you see how the microcatheter from the vein is exactly in the same location, okay? And then indeed, like after the first arterial injection, now at this point, same angiography, we start injecting from the vein, and we confirm that we are exactly in the same spot. at this point, like honestly, like the treatment, what to do, becomes very obvious and very simple. And we started like coil off the sinus first with detachable coils, and then we completed with some pushable coils. And you see how the coil really like are here, like surrounding on this AP view, surrounding the ICA, and by the time of the third coil, the flow was gone. And this is like an external carotid injection. And you see how now like we see like still like we see the foramen rotundum, because are feeling like through collateral, like arterial to arterial, they're feeling together, but there's no fistula. And this is again that a semipharyngeal clavicle branch, and you see how now you see filling of all the arteries, but there is no fistula left. And you want to control every vessel. ICA, no collaterals, sorry, no filling of the fistula. And here I want to point on this image something. So let me show you. This is the final ICA run, and becomes interesting to see like how it is compared to before, because even if the patient didn't have any issue with the in terms of seizure or other brain problems, like we noticed on the MRI and the angiogram how there was congestion, right? So this is the initial angiogram, and you see how you notice here the venous congestion. Okay, so you see how the vein here are tortuous, are congested, some are increasing size, and you see this sort of like enhancement, like that tells us that the brain has a little tough time here draining in this area, which is exactly in the temporal, insular, inferior frontal lobe. Now this is post treatment, and what you notice here is that is much less. And if anything, actually, now we see that the brain is actually using this vein, which was used by the fistula before. And now the brain is draining through this inferior temporal, like sort of like entorial vein that couldn't do before because of the fistula. So this really like confirms that this was cured with no flow to the veins anymore. And I believe that's it. I don't know if there's any question, anything you want to show more on this case, but I think that those were the most important things to show.
Thanks, Eitan. Any comments from anyone about the transorbital approach?
Thanks, Ethan. I have heard people doing this, never done one myself. Did you, you did this on the same day, right? The whole thing?
The angio one day, thanks for asking. I think that's a very, very important point. We did the angiogram on one day, and we did the treatment the day after. And I think that's very important, because, you know, this is a complex disease to really like understand in detail. And I think it's important to acquire the images and think about it, look at them, really like learn very well the specific patient's anatomy, and then develop your plan, and really just go for your treatment only with already like the knowledge of the anatomy.
Yeah, I really do agree to that. But my question was actually about the transorbital thing. I would be quite scared, because it's, as you've said, it's very close to the internal carotid artery, and it probably has a different risk to the patient. So do you give the informed consent of explaining all the variations, including the transorbital approach?
Yeah, no, that's a good point. And I mean, we thought about the orbital approach before going for treatment. So he was consented for all sort of 3 treatments. Now, in terms of the the risk of the direct transorbital puncture. It's actually like interesting when you look at the main studies from that were published about that. Like the risks don't seem to be that high if done properly. It's interesting, right? To us it seems like a very like invasive and almost traumatic way to treat. But when you look at the numbers, actually the risk don't seem that high. I don't think ever there was a case report of retrobulbar hematoma from this. You know where the optic nerve and the optic foramen is, so really you have to stay lateral to that, and that becomes you know, like something obviously to be careful about. The carotid, if you look at the lateral view, careful during the needle advancement. You know, you have to be anterior to the carotid, and I'm sure there's a risk of like going too deep and hitting that. You know, like by looking at the literature, it seems like the risks are not that high as we may think at first glance.
Yeah, I think the issue is that the literature is not, you know, very voluminous, right? There are a couple of groups that kind of concentrate on that. And so the real question, like at this point, is it doesn't seem like the risk is as high as it might appear, at least like psychologically. But what the real risk is a question. And also it relates to like, what's the relative risk of that versus, I think the real question is what's the risk of that versus the transarterial approach? Because that would be the question. Or like an open surgical exposure, and you know, like that be done occasionally.
Yeah, I would think of like surgical exposure of the SMCV and do cannulation from there. For us, I feel it would be safer for us at least.
Yeah.
And there's a question whether you can approach to the SOV. You can go through that or not. I don't see any connection.
The SOV here was small. I mean, certainly there is a way, but the SOV actually is
cavernous sinus and fill it with Surgicel or fill it with other material.
Sorry, Henry, what did you say?
Yeah, no, I mean, I think that all of those options are available options, and I've done all of them. You know, SOV cut down to get into the cavernous sinus. If the SOV is too tortuous or too small, you can direct stick the sinus. I have also opened the lateral aspect of the cavernous sinus and filled it with Surgicel. I mean, that was the traditional surgical treatment for cavernous sinus fistulas in the past. You know, obviously the endovascular approaches are, you know, much less invasive than the full carional craniotomy, sylvian fissure cut down, and cutting the lateral aspect of the cavernous sinus.
Yeah.
So yeah, a couple of, to follow up on that, there was like some questions in the Zoom chat. Was the superior ophthalmic vein big enough to direct puncture? So in this case, maybe you can show Eitan the SOV.
Yeah.
Yeah, you can probably direct puncture the SOV as well, but the problem with direct puncture of the SOV is that it's so mobile in the periorbital fat. If you get it surgically, and if your oculoplastic surgeon becomes skilled at it, they can get it very, very easily, typically proximal to where there's curvature at the angular vein. And so that way your needle doesn't move the vessel while you're trying to stick it. But if the SOV is big enough, you can certainly direct puncture it.
Yeah, that's what we used to do if the SOV was big, that's exactly, we would have oculoplastic exposed.
Yeah, what was your...
Here, this is the SOV. The SOV, that's certainly like an option here, but it would have, I think it's too small it would require like a cut down.
I think also the anatomical point that just want to mention is, and we've seen this time and again, like with cavernous sinus fistulas, and I'm sure those of you that have seen a lot of them know this very well, is that the symptoms, the size of the vein is not related to the size of the symptoms, right? Like the guy probably had a bigger SOV maybe at some point, and now it's either thrombosing or it's closing down. And so he presents with ocular symptoms. He has like a significant proptosis. He has engorged veins there. But if you look at the drainage of this fistula, it doesn't seem like it's really angrily draining into the eye, yet the eye is profoundly affected. We have other cases, I mean, it's a little late, but we could show cases where there's minimal apparent drainage into the eye, yet the person is almost blind because there's no other outflow and there's tremendous venous congestion in there, just not very obvious. So that's just a related point because I think it's nicely illustrated in this case. Couple of other questions. Ophthalmology help retracting. Edgar is asking, did we have ophthalmology retracting the globe? No, right? Eitan, maybe.
No, we didn't need it here. So there was a good route without need for that.
Yeah, I don't think you need that. The proptosis also helps because the proptosis pushes the eye forward in a way. So like if you like feel where the eye is, you notice that you're like, the globe is like halfway out. And I don't think that's a big issue. Do you have, and then Jacques?
I think in that lateral image that he has there, you can see the relationship of the needle with the globe, you know, because you're opacifying the globe there, and it goes underneath basically in lateral. So I think, you know, just like Dan Saline was suggesting, you know, there's no average. You know, sometimes there's a huge ophthalmic vein and it's easy to retrogradely catheterize from the facial vein and you do it that way. Or you can do it with ophthalmology, but I think we started going to this because, you know, of the frustration of dealing sometimes with ophthalmology cutting down a small vein, and it just seems that occasionally that procedure takes several hours. And similarly, like Eitan had tried here, recanalizing the inferior petrosal sinus. So I think that there are just many ways to skin a cat. I do want to just mention one thing. In doing many of these in the past, we have gotten into the internal carotid artery. And strangely enough, that usually can take care of itself. So just puncturing the carotid artery, while you try to avoid it, and you can use road maps, arterial road maps to kind of place your needle, if you do accidentally lance the internal carotid artery, it's not necessarily a catastrophe. What has to happen though is you have to coil off the cavernous sinus so you don't end up with a CC fistula. But it's just like puncturing any artery. You can get by with without doing it. Now, you don't want to inject something, so you need to know where your needle is, but that isn't necessarily you know, catastrophic. The bigger issue is if you were to accidentally get into the optic nerve or something like this.
Okay, so a few more questions. You have John Scott, oculoplastics on standby in case there's decompression necessary. You want to comment? I mean, we don't have them in the room, you know, because they're not doing a cut down.
John, no, that's true. Like, you know, like that's the thing that we're scared about, right? Like a retroorbital hematoma, right? Interesting, like, and that's to me, like when I had chance like to review the literature recently, and I didn't find any description of a retrobulbar hematoma with direct puncture. I'm sure it's there and I couldn't find it, but it doesn't seem to be like a common issue with this approach.
I think the key thing, Eitan, is if you puncture this and don't close the fistula, then you have an arterialized cavernous sinus that potentially could bleed along the tract of the needle. But once you close the sinus, it's really kind of at a venous pressure. And so I don't think it's a particularly, you know, frequent hazard.
Okay, Sri is asking, once placed, how do you stabilize your needle to push the microcatheter? Any tips?
So I think that to answer this question, it becomes important the length of the needle. Like this needle, like was really like the perfect length. I think it was around 6.5 centimeter. So it's really like it's very stable because it doesn't go out of the orbit much. It's really like maxed out almost there. So it becomes very stable. You know, you connect it with a tube like a tube extension, and you secure it with some tape and becomes very stable.
So the tube is secured with the tape, right? So
Yeah.
and you have like a Y connector, and like you have a pressure line with a Y connector, stick it on the needle, and through the Y connector you thread your microcatheter, right? Or like you have a tube and then the Y connector later, so you don't touch the needle while it's being maneuvered. I suppose that would be the related question. Say you put the needle in there and then suddenly the needle somehow is dislodged, and then you have like a hole in the sinus with a connection to the orbit or tissue. So I guess that might be a problem. From Diego, what about trying to get to the pouch via the contralateral inferior petrosal sinus?
That's certainly like it's another option, and you know, we could have in such a case you can keep trying. You know, you can keep trying and like, you know, from the other side, certainly like from the clivus it would not have been possible because we did opacify actually the contralateral IPS from the right IPS through the clivus, so that's not an option. You're mentioning through the intercavernous sinus. You know, we never saw an intercavernous sinus patent here. The fistula, we know it doesn't drain through that. So if there is an intercavernous sinus, it's probably very small and hence hard to catheterize. So I'm sure it's an option, but at a certain point, you know, like the case becomes long, the frustration increases, and that's where the issue like start to come up, as Dr. Nelson always taught me. So, you know, you certainly can keep trying, but you know, like at a certain point, I think it's good to go for what you think is your best shot.
Actually, I think Kitty Pong had raised that issue of, do you do the angio on the same day or a different day? And you know, frequently a good angio, as you did here with the 3D reconstructions, and that can take like 2-3 hours. And so you get there and then you play around with the inferior petrosal sinus approach, and you don't want to start doing this 5-6 hours into a case. You know, it's better to like have a plan that you develop on your angiogram, and then you go and it becomes a 1-2 hour case, and so you're fresh and your likelihood of ending up with a complication is less. But you definitely don't want to go to this at the end of 5-6 hours of wrestling with a case. You know, you want to come to it with a fresh approach.
And I think it's important to mention that, like, I'm sure questions come up like, what's the total dose? Like, what are the radiation implications of like all of this imaging? I mean, a couple of points I think are worth mentioning. Number one is like, and we'll have a separate lecture on that, is about technique. Like, we do all of our runs are at 2 per second. Like, we don't have 3 per second runs as a rule. Sometimes you could go to 1 per second. Collimation, like all of these things. And I think it's very important because like these are obviously long procedures. Also, the machine is modern. Like, not everybody is blessed with having this like state-of-the-art machine that not only produces great images, but it also is like way less radiation than what we had 10 years ago. If we were doing it on a machine that's 15 years old, we wouldn't have the dyna capability, and we'd probably end up with 3 times the dose that we did. So I think that is something to keep in mind when we have this approach, is that modern imaging is allowing us to do that.
So as a disclosure, the needle approach was done by Dr. Nelson.
Good, thank you. So that takes us to almost 10 o'clock. We wanted to cover one subject that we had great cases here. We didn't have chance to cover the venous sinus stenosis and pulsatile tinnitus, which I think is a subject that we haven't really addressed here, but it's certainly is venous very much, and takes us into this whole other world of like venous relationship between venous and cerebrospinal fluid dynamics. I think it's very important. I don't know if we want to briefly cover it or should we leave it for later. Any votes? Anybody wants to? Maybe have 50 guys left, people left. So I don't know. What do we think? Should we do it? Should we not do it? Leave it for later. We can have, certainly we have like maybe an extra session. We can cover that specifically because I think that deserves some discussion. There's a lot of stuff that can come out of that.
Stop sharing my screen.
All right. Okay, thank you. Let's see. Again, it's almost 10. Hema, are you around?
Yes.
Hema, do you want to leave it for later too, or do you want to do your case now? How long you think you got?
As is okay. It's just a 2-minute case that I wanted to show.
Okay, cool. Let's do that then.
Yeah. So. Can you see the screen?
Yep.
So this was a young lady for 21-year-old, 14 days postpartum. The thing why I present this case is because we have a lot of postpartum women with a lot of neurovascular conditions coming to our hospital referred all the time. She came with acute progressive right-sided hemicranial headache of 6 days duration and acute progressive complete weakness of left upper and lower limb of 3 days duration, slurring of speech. There was no history of fever, vomiting, convulsion, or loss of consciousness to suggest an infective etiology to what she was presenting with. The thing is, I would deviate a little from the angiograms, but I only wanted to show this because we saw a very interesting case that Ethan showed of a unilateral basal vein thrombosis that he picked up on angiogram. So it is a similar case that we had. It's a little more obvious, I would say. This was the first CT scan that the patient had when she came to the emergency. We can see that there is a hypointensity in the right thalamic region. She underwent a post-contrast CT, which shows the right basal vein of Rosenthal, but sorry, the left basal vein of Rosenthal, but the right one is not seen. Of course, we could attribute it to an asymmetry of imaging at times when we are not able to see the second basal vein of Rosenthal or structures which are symmetrical on both sides. Patient underwent an MR which showed hypointensity in the same region with perilesional edema. That's the FLAIR image. We see the hypointensity and the perilesional edema here. That's the T1 weighted image where we can see a hyperintensity extending along the cistern here and along the tentorium here, going posteriorly to the straight sinus. Gradient showed a hemorrhagic focus in the right thalamus. Again, hypointensity is going towards the straight sinus. And the diffusion weighted image, of course, showed a focal diffusion restriction in this region, secondary to the hemorrhage that she had. And when we did an SWR for the patient, we can see that the entire right basal vein of Rosenthal was thrombosed, leading to the imaging features that we are seeing on the CT and the MR. So that's the post-contrast image. We can see the enhancement well on the left side, but not on the right side. Differentials could have been in case of if had there been a history of fever, we could have thought of infective etiologies to this, or maybe encephalitis. But since the patient did not have any of those histories, those possibilities were ruled out. Other thing is because given, as I said, we have a lot of patients coming with CVT, we always look at the veins very carefully. And this was just to say that basal vein can have a unilateral thrombosis, which might be apparent very well on MRI.
Thank you, Hema. Very nice case. Any comments? Questions? What do we think about the distribution of the edema? Did you have any, was there anything in the thalamus, or did I don't know if I saw it. Okay, so that's coming up a little bit towards, there's just midbrain, right?
Yeah, it was a little more.
Interesting. So we take it the internal cerebral vein was okay, right?
Yes, the internal cerebral vein was okay.
Mm-hmm. Is that a dural channel where this basal vein drains into? You see how it has this funny course?
Yes. The posterior one, this one?
Yeah.
Yes. Because even when we look at the T1 weighted here, we can see that this is what the course of the BVR obviously is, but this is along the tentorium that we are seeing. So probably it's extending from the basal vein to the stentorial channel, which goes posteriorly.
Yeah, that's okay. So we touched on that in the past, that there's a lot of these dural kind of like tentorial sinuses that drain the basal vein and other cerebellar veins. And particularly, so there is like, you can't hang your head on that, but there's often an association of the vein size. So the larger the vein, the more likely it is to have kept like this tentorial sinus. So probably was a pretty big basal vein. to begin with, and hence the problem. So there is some thalamic stuff here going on, right? So the hemorrhage, or like the venous congestion, extends into the thalamus, which is interesting, right, Hema, because you would, like, is that typically the territory where the basal vein that collects into the basal vein, do we think?
No,
or
because
the thalamus drains somewhere else?
yes, because we don't see the internal cerebral veins or the other veins draining the thalamus to be thrombosed.
So there might be some variance, right, or some
Yes.
extension of the thrombus into these veins. What do we think?
Can you show also again the flare before, like, or T2? Oh, we don't. Yeah, it doesn't go to the thalamus, because on that SWI, it seems the left thalamus also is edematous, but that's not the right. If you go back to that SWI or GRE, yeah. So here on the left thalamus, but this is not the right sequence to look at it. But the left thalamus seems also a little brighter.
This one, yeah.
It is interesting.
Yeah, so yeah, speaking of anatomy, we have two veins from the thalamus draining into the basal vein of Rosenthal. Typically, the inferior and posterior thalamic veins should drain into this basal vein of Rosenthal. That's why we have some problem inside the thalamus also. So that makes sense.
Right. Hema, thank you so much. It's a really, really cool case.
Thank you.
Treatment is the usual, anticoagulation.
Yes.
All right. Cool.
Yes.
All right. So, okay, thank you. So we are over time. I want to thank everybody for coming, sharing, and participating. We've had a really, I think we've dedicated a lot of time to the veins. We're not done yet. We'll do more. There's going to be, so next week is, we'll have an Embo Club. So if you have any cases to show, let us know. Show your cases, please. And then after that, June, June when? The last, June 30th. So the last Tuesday of June, we are dedicating to the fellows. So like, basically we want to let your fellows know, if you're a fellow, if you're not, let the fellows know that they're encouraged to submit any cases or any presentations that they may want to share with the group, as a way of both encouraging participation and recognizing the contribution of the fellows. So like traditionally, like at least in the States, July, like June 30th is the last day. July 1st is a new cycle of the fellowship. And so a lot of what we're doing here is obviously geared towards education of the fellows. And so please, if you have cases, submit them, let me know. We have a couple of people that already signed up, and we have room for more. So again, thank you so much. I will see you next Tuesday.